Assalamu alaikum and good evening to you all. Welcome to the fifth episode of Masterclass for Medicine Final Part Examinee organized by ACP Bangladesh Chapter and supported by Bangladesh Society of Medicine. As you already know, it is a program which is designed for the Medicine Final Part Examinee as well as Midterm Preliminary Part 2 examinees. On today's episode, we will be discussing about the topic you will all been waiting for. Today, we will be learning about the updates on COVID 19. To talk about this important topic, we have someone who is considered one of the most up to date and knowledgeable professor of our time, Professor Ahmedul Kabir sir. He is the principal and professor of medicine, Mugda Medical College, and he is also the Secretary General of Bangladesh Society of Medicine. To chair the session, we have the legend of the legends himself, Professor Kaji Tarikul Islam sir. He was the founder governor of ACP Bangladesh chapter and former president of Bangladesh Society of Medicine. In the expert panel, we have two most renowned and prestigious professors of our country. Firstly, we have Professor Aniruddha Ghose. He is the professor, Department of Medicine, Chittagong Medical College. Then we have Professor Ahmed Hossain sir. He is the head and professor of medicine, Sir Solimullah Medical College. As a moderator, we have the beautiful and talented Dr. Mousumi Sanyal. She is the consultant of medicine, Central Police Hospital. During the live session, you can ask topic related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Mousumi Sanyal. Dr. Mousumi Sanyal.
Hello.
Thank you, Dr. Kawser. Can you hear me?
Yeah,
Can
Mousumi.
everyone hear me?
Yes.
Welcome,
Loud
sir.
and clear. Yes, sir. How are you
Welcome
doing?
everyone in today's session. So today we are getting together in the update of COVID-19 and I hope that we'll have a very good time. প্রথমে আমি সবাইকে শুভেচ্ছা জানাচ্ছি। আজকে আমাদের আষাঢ়ের প্রথম দিন, বর্ষাকাল শুরু হচ্ছে আর আমরা এখন একটা কঠিন সময়ের মধ্যে দিয়ে যাচ্ছি, কোভিড-19 প্যান্ডেমিক। আমরা প্রথমেই কৃতজ্ঞতা জানাচ্ছি আমেরিকান কলেজ অফ ফিজিশিয়ানসের বাংলাদেশ চ্যাপ্টার এবং বাংলাদেশ সোসাইটি অফ মেডিসিনকে এই গেট টুগেদার এবং এই আলোচনার একটা সুযোগ করে দেওয়ার জন্য। আজকে এই অনুষ্ঠানে আমাদের সাথে আছেন আমাদের লিজেন্ডারি সব প্রফেসর। আমি ডক্টর মৌসুমী সামনাম মডারেটর হিসেবে আছি এবং তাদের সাথে স্ক্রিন শেয়ার করাটা আমার জীবনের অন্যতম সৌভাগ্য। আমি সব স্যারেরই ছাত্রী ছিলাম। আমি এখন বর্তমানে কাজ করছি মেডিসিন কনসালটেন্ট হিসেবে সেন্ট্রাল পুলিশ হাসপাতালে এবং আজকে আমাদের অনুষ্ঠানে কি স্পিকার হিসেবে আছেন আমাদের লেজেন্ডারি প্রফেসর আহমেদুল কবির স্যার। তার বর্তমানে মুগদা মেডিকেল কলেজে অধ্যক্ষ হিসেবে কর্মরত আছেন, কিন্তু এছাড়াও স্যারের আরেকটা পরিচয়, উনি আমাদের বর্তমান মেডিসিনের যে সমাজটা আছে, সোসাইটিটা আছে, তার অন্যতম বলবো দিক নির্দেশনা দান করেন। তিনি একাধারে আমেরিকান কলেজ অফ ফিজিশিয়ান এবং বাংলাদেশ সোসাইটি অফ মেডিসিন দুই ক্ষেত্রেই কর্মরত আছেন সেক্রেটারি জেনারেল হিসেবে। এরপরে আমাদের চেয়ারপারসন হিসেবে আজকে অনুষ্ঠানে আছেন প্রফেসর কাবির ইসলাম স্যার। স্যার ফর্মার গভর্নর এসিপি বাংলাদেশ চ্যাপ্টার এবং ফর্মার প্রেসিডেন্ট বাংলাদেশ সোসাইটি অফ মেডিসিনের। কিন্তু এইগুলো পরিচয়ের বাইরেও আমরা সবাই স্যারকে চিনি যে স্যার আমাদের সবচেয়ে বড় স্যার। উনি আমাদেরকে খুবই স্নেহ করেন, কাজেই তাকে আলাদা করে পরিচয় করে দেওয়ার কিছু নেই। এছাড়া আছেন আমাদের সাথে প্যানেল অফ এক্সপার্ট প্রফেসর অনিরুদ্ধ ঘোষ, প্রফেসর ডিপার্টমেন্ট অফ মেডিসিন, চিটং মেডিকেল কলেজ, চিটং। আমি কিন্তু স্যারের ছাত্রী ছিলাম 5th ইয়ারে। স্যারের আমাকে মনে নেই, কারণ এরপরে আর যাওয়া হয় নাই। আর এছাড়াও আছেন প্রফেসর আহমেদ হোসেন, স্যার হেড অফ দ্য ডিপার্টমেন্ট অ্যান্ড প্রফেসর অফ মেডিসিন, স্যার সলিমুল্লাহ মেডিকেল কলেজে। এখন আমি প্রথমেই প্রফেসর আহমেদুল কবির স্যারকে অনুরোধ করব আমাদের আজকের টপিক আপডেট অন কোভিড-19 এর উপরে স্যার প্রেজেন্টেশনটা শুরু করার জন্য। আহমেদুল কবির স্যার।
Thank you, Dr. Mousumi. Thank you for your very good introduction. really proud to see you in the same platform. Mousumi was my student, and today she introduced me in a very nice way. And also, I'm really very happy to talk in front of my two teacher. One is Professor Kazi Tariq sir, who is our mentor as well as dynamic leader in the field of internal medicine, and who was the governor of ACP Bangladesh chapter. His visionary leadership was really vibrant, and as well as I can see the present ACP governor, Professor H.M. Nazmul Hassan. Sir, possibly you are not, you were staying abroad. From far away, you joined to this session. And I can see in the panel my very beloved Professor Aniruddha. And also, I can see my respected Professor Ahmedul is there as well. So, before beginning, I'm not in a very good mental state at the moment, or you can say physical state as well, because of the current situation is again going worsening. I just rushed from my chamber instead for this program. I came home right now and had a very hurry preparation because today I have seen many cases in my chamber in the COVID that was not present for the last, you can say, 1 month. The condition of the city is also getting worsened day by day. So I'm really in a fear that the wave which started from the border zone will soon enter in the Dhaka city, and what is the next situation, only the Almighty knows. Against this background, I have been asked to say about the update on COVID-19. Really, where to begin, where to end is a huge chapter, and COVID-19 is not now a COVID-19. It became COVID 20, 21, 23, and so on. It might be COVID 24 or 25. The way the COVID entered, and there were frequent cycle is there, and ups and downs will go on. The weak systems we are trying to combat the COVID is no more fit for my country, because if we want to have a rock solid foundation to prevent COVID, we need a vaccine, which become very rare at the moment to the country. Against this background, I'm going to say something about the update. If you just look at this condition, there was an unknown virus. It emerges in the Wuhan, China, and that was a very sporadic situation. Then it rapidly processed to the stage 2 that became where the pandemic unfolded. And after that, the pandemic accelerated in the stage 3. And finally, there is a multifaceted pandemic. And now, when there is a multifaceted endemic in the stage 4, the stage 5, where the medical countermeasures begin in actions. But if you can see what happened to this unknown virus emerges in a city of Wuhan, where you can see a group of people standing in front of a building, the things becomes very clear what is happening there. Some cases linked to the seafood market in Wuhan, Hubei province. Some patient died, especially elderly with other comorbidities. And a new disease came to play, is known as the novel coronavirus. As all of you know, this family of virus is known to infect animals and human. The infection causing respiratory disease ranging from mild to severe disease. At that time, there was no idea, and we know little about the disease, and there was no death related to COVID-19 was recorded outside the China. Soon, the disease spread outside of the China. So if you look at the stages, how the COVID beginning to ended, where we started, where we ended, there was the initial response to the virus in the 31st December in 2019, where cluster of pneumonia was detected in Wuhan. And following that, in 5th January, WHO issue first disease outbreak news, followed by 23rd January, there is a restriction in Wuhan, all transport in and out of the Wuhan suspended. And finally, 30 June, WHO declares this is a public health emergency of international concern. And in 4th February, strategic preparedness and response plan issued. And finally, on 11th March, WHO described it as a COVID-19 as a pandemic. So it becomes a disaster for the whole world. So what is happening in stage 1? There were many research gone. There were many diagnostic facilities discovered, and the researchers started to begin their work on producing vaccine and therapeutics. They started immediately. And as you know, there is a research and development blueprint, and WHO convened the first global COVID-19 research and innovation forum in Geneva on 11 to 12 February 2020. And as a whole, what actually we know about the COVID viruses or coronaviruses family, it begin in different format. In if you go to back to the history in November 2002 to July 2003, in the China to Toronto, the spread was limited to China to Toronto. There was 8,096 cases, and case fatality rate was only 9.5, and that was known as SARS, as all of you know. Following this, the another name this started as MARS, which began in Saudi Arabia in 2012, and 2,260 cases was there. Few small clusters were there, and case fatality rose to 34.4%. Finally, the newer form, which started in Guangzhou, China, secondary attacks and pre-symptomatic cases increased. There was 3.3% overall, 16.1% household, 1.1% social contact, and this name as SARS-CoV-2. If we look at the human coronavirus phylogenetic tree, it is an alpha virus, delta virus, and beta coronavirus. We are concerned with the beta coronavirus. And if look at the microscopy of this one, this has got a spike protein which has got S1 and S2 protein, and this has got a receptor binding domain which is to attach with the ACE receptor of the human cell. And the virus having a spike protein, it has got a single stranded RNA. There are nucleocapsid and envelope protein is there. And why the virus structure is important, because all the discoveries vaccine is based on this virus structure. The whole hurtful feedback of the pathophysiology of COVID-19, if you see, this is a cascade of cycle where it begins, where it ends. If you look at this slide, you can see there were, after the virus invading to the lungs and other tissue, what sort of damage is there. There was diffuse alveolar damage occurs due to the lot of tsunamis there, cytokine storm cells, cytokine, chemokines, T cell lymphokine, cytokine release factors, nitric oxide generator, prostaglandin I2 inhibitor, vascular leakage, and a lot of other things are there. Platelet dysfunction is also occurring, apoptosis, and many more things, and leading rise to diffuse alveolar damage. And also there is pathogen associated molecular pattern and damage associated molecular pattern. This is in a short the tsunami occurs in human body after getting the infection. This is a pathophysiology. If you look now as a major risk factors, who are actually in the race? Less than 10 years, COVID-19 percentage of all cases is very low, and the incubation period, if you look, and disease outset, and mainly they used to follow the mild disease, 81% cases. Those who are more than 60 years, they are likely to get a severe disease, and there are 14%, and the patient generally present with dyspnea, and they usually needed, some of them require ICU support. Those who are above 80 years, they are likely to develop critical, and they have a disease of 5%, and used to develop ARDS, acute cardiac injury, and multi-organ failure. Now the stage 2, the pandemic unfolds. Is you see in stage 2, there were 124,518 cases confirmed and 4,607 deaths. And the death number since 12 March 2020, there are over 120,000 cases and over 4,600 deaths. How the disease is spreading throughout the globe. We could not prevent that. But one thing is that how the COVID-19 is spread outside China. You see from there, from China to Brazil, to Italy, to Iran, to whole world, it has spread. The main reason is a mass gathering such as religious event in the city of Daegu in Seoul, South Korea, religious gathering in Iran, then many more spaces. There was a football match in Italy. They played the key role, and the case fatalities also become higher in Italy. And early information is that elderly people are getting more and more infected. And following the 11 March, there was a global pandemic. Now, the thing is that China could have successfully managed the COVID in their territory. That is really surprising. And WHO China Joint Commission report has a lot of suggestion for the rest of the world, but none of the state followed that, and they did not follow globally same principle. That's why the scenario is like this. Number one, there was no reported case, and then there was a sporadic case, ultimately cluster of case, and finally the ultimate punishment is the community transmission because of not following the rules and regulation. In many countries, spread of COVID-19 leads to community transmission. So what is happening to the pandemic when unfolded? Then WHO came to role to play implementation of the public and social measures, what personal protective measures started to be taken, travel related, a lot of measures has been taken, social distancing measures has been taken, and also environmental measures was also taken. Uh, Let's see what happened to the next level. Health system when under huge pressure, even in the wealthy countries. Hospitals and health workers face a rising demand to attend to a growing number of COVID-19 patients. Ultimately, there were personal protective equipment shortening, oxygen shortage, ventilator shortage, COVID-19 diagnostic shortage, and healthcare workers were severely affected. And finally, what happened? If we look back, Bangladesh Society of Medicine at the beginning, where in Wuhan city it started in January 2020. The eminent professor who is standing here also in the here today's panel, he is also there, Professor Kaji Tariq sir. I should respect his full-hearted support to bring this COVID-19 interim guideline, following the WHO interim guideline. And there was a huge gathering in Dhaka Medical College where we started to raise this guideline to come to play a role about empowering the people. And following that, CDC followed our guideline, and finally we came to the ninth version of this COVID-19 management guideline. And this is a living guideline, and ultimately we have brought out the short edition of ninth version on just recent few days earlier. So why I'm saying this, if you can go through this national guideline on COVID clinical management, you can get all the things you require for your exam related issues. Yes, I will be highlighting this issue to stimulate yourself to go through all these things. It may not be possible for me to cover all aspects of the COVID, though I have been asked to speak about update. It's a huge thing, it's an ocean. So it's not possible. I'll be just highlighting the important issues. Rest you can find from our guideline. So coming back to the subject, you see the incubation period and followed by the median days of onset of development of initial symptoms. So you see the symptoms were this, all of you know the onset of symptoms, fever, cough, fatigue, and all these symptoms, anorexia, a lot of other symptoms are there. And ultimately, after 7 or 8 days, patient may proceed to the critical illness or can recover, and dyspnea occurs in 40% of the symptomatic patients. When do symptoms start? And if you see how long does risk of infection or the last? According to CDC advice, 10 days isolation from first symptoms. So you see the red mark, symptoms to 10 days, up to 6 days is a highly infectious. So exposure up to 6 days highly infectious. Then the rest of the 7, 8, 9, 10 days is infectious. After 10 days, in fact, generally CDC says that isolation from first after 10 days, the patient is no more infectious if the case is not severe. But if the case is severe, severe case may be infectious for longer periods even. Now I'm quickly reviewing these risk factors for severe COVID-19, because you know the established and potential risk factors for severe COVID-19 are those who are elderly, obese, and are having a COPD or lung disease, the patients who are immunocompromised, having cardiovascular disease, end-stage renal disease, diabetes mellitus, and liver disease as well. Next. How is care of COVID-19 patient determined? So what are the resource requirement? What is the severity? Resource requirement is beginning from isolation, oxygen therapy to mechanical ventilation, and how progressively the patient can begin from mild to critical illness. So if you just look at this slide, you can see the before symptom onset, detection unlikely because the patient is not symptomatic. Then after the exposure, what is happening? The symptom onset in the first week when the viremia is there, after serum PCR is likely to be positive, and after 1 or 2 weeks, in middle you see the end of the 1 week antibody detection appears, and after 7 days PCR unlikely, and it likely to be negative. So the first week the PCR positive is very high. After the first week there is antibody production, and this is the critical moment when patient becomes severely ill between the first and second week. Next. So effective and equitable decision making is very important. So next. Now, how COVID-19 treatments could work? If you look, this is a virus. So antiviral drugs prevent virus from multiplying. Anti-inflammatory drugs, it can dampen the immune response and stops the cytokine storm in the patient's body. Immune system is dangerously overwhelmed by virus, so it needs the anti-inflammatory drugs. And finally, you see the antibody treatment. So antibody is specific to the coronavirus, binds to it and kill it. So these are the three ways we can actually specifically treat this condition. Next, Center for Drug Evaluation Research Response to COVID-19 is trying a lot of ways how we can prevent and treat this disease. It begins with the January 2020 to February 1, 2021. Next. Now, what's the projected timeline for treatment and prevention? There are 66 programs working on 3 different approaches. Some are using repurposed drugs, antibodies, vaccine. So a lot of vaccines are now in trial, and a lot of antibodies are also in trial. Some are in the phase 1, some are in phase 2, and many are in phase 2, 3 trials. These are repurposed drugs, antibiotics, vaccine. People tried in different way. There are infodemics, and a lot of information came. Some became overuse and repurposed use also there. Drug which are repurposed use approach to fight COVID-19. There were based on these many drugs were there which are AC down regulation, then also proteolysis and packaging, exocytosis, transcription and translation, and a lot of places nucleic acid release, and many places here all this drug has been used. So basically the therapeutic targets of the currently considered drugs for repurposing use against COVID-19 were many drugs which are not being used nowadays. I don't want to go to this, and I'm going to the next slide. If you can see, the many drug has been tried since January 20. So FDA announced many ways of mine March 28, then followed by April 17. And in April 17 to May 8, remdesivir gained emergency use authorization from FDA. And there were convalescent plasma, which was also got FDA announces national EAP for convalescent plasma on April 3. FDA's emergency use authorization in March 28. Then FDA revoked EUA for use of hydroxychloroquine and chloroquine in June 15. And finally, FDA broadened remdesivir emergency use to include in moderate COVID-19. Finally, in November 9, FDA issued an emergency use authorization for antibody bemnifosbuvir. So, the clinical courses of the disease. If you look at the severity of the illness, the early stage of viral response, then the pulmonary phase, then the host inflammatory response is there, and then finally the hyperinflammatory phase. This is the time course needed for addressing the treatment of patients. So these are the potential therapeutics where the which drug is being used, where immunomodulator drug needs to be used, where the steroid should be used. All these, if you understand the pathophysiology, it could be easier for treating the patients. Severity of the illness, generally viremic phases, there is a host viral response occurs, and this is the time where antiviral drugs can be used if it is given very early stage. Then the pulmonary phase and severe phase, where the host inflammatory response is very high, and there you must use some immunomodulatory drug along with the antiviral, that is corticosteroids, anticoagulant, and also anti-inflammatory drug. And finally, in the severe stage, corticosteroid, anticoagulant, IL-6 inhibitors, JAK inhibitors, and anti-inflammatory and immunomodulatory therapy. Because it's individual judgment and clinician must be, the patient's treatment is individualized. That's why the clinician must understand which drug works in which stage and which phases. That is very important. This is a very clumsy slide about the pathophysiology and others. I do not want to elaborate this. Next. This is from our national guideline on COVID-19 management in Bangladesh, version 9. You will all have there. You might have gone through you see the symptoms of COVID-19. The main symptom is fever, cough, shortness of breath, and loss of taste and smell. Other symptoms which are myalgia, fatigue, and a lot of other symptoms have already been stated. Now, how to proceed towards the, yes, if these symptoms are there, and do a COVID test. If it is positive, then you need to clinically evaluate the cases, or if it is suspected COVID case, and then follow this graph. If the patient is having visible respiratory distress, SpO2 less than 93, moderate, severe, critical illness, you need to admit the patient, and you have to start oxygen if the SpO2 is less than 90. And for critical ill patient, start resuscitating the patient at twice. If there are no severe symptoms, no visible respiratory distress, normal clinical examination, SpO2 more than 93, so consider as mild cases, no need for admission. Manage mild case accordingly. If there are no such symptoms, COVID unlikely, and refer to non-COVID section of the hospital and investigate and manage accordingly. Lot of extrapulmonary manifestations of COVID-19, meanwhile, we came to know. Many will come also. No system of the body is immune from COVID. From dermatology to cardiac to endocrine, GI, neurological, thromboembolism, hepatic, renal, everywhere COVID has its imprint. Lot of dermatological manifestations are there, and many cardiac problem, from carditis to cardiogenic shock, even myocardial ischemia, cardiac arrhythmia, and patient might have developed new diabetes due to the destruction of the pancreatic beta cell by COVID. And the GI symptoms also dominant in some of the cases, and there were Guillain-Barré syndrome, stroke, myalgia, encephalopathy. These are the neurological manifestations, and more dear complications of deep vein thrombosis, pulmonary embolism, like this. So this is actually the twice flowchart. It's already been mentioned. If there is a symptoms, what you'll be doing. If there's suspected COVID, in which way you go, and unlikely COVID, what to do. So I'm going to the next slide because I think many things still remain. So what about the goal of therapy? We can begin with the nasal cannula, 6 liter per minute oxygen. If the SpO2 still less than 90, if the SpO2 is less than 88, change to simple mask. Still, if it is less than 88, progressively you need to increase the oxygen flow. Then you'll have to go to the non-rebreather mask. If it is still, you cannot control the patient with non-rebreather mask, and the oxygen saturation remain less than 88, have to go to the high flow nasal cannula. Even after using high flow nasal cannula, patient cannot maintain SpO2 less than, still become less than 88. Then you have to go to non-invasive ventilation like CPAP, BiPAP. After even using the NIV, the SpO2 still remains less than 88. That means the patient is gravely ill. Consideration of giving of mechanical ventilation. This is the follow chart. You should not have a temptation to jump from one to other. You will have to exhaust all the oxygen delivery system before going to the mechanical ventilation. On all the aspect, you must be very careful keeping the patient in awake proning. And your goal of therapy is to keep patient's partial pressure of oxygen more than 55, SpO2 more than 88, pH more than 7.3, and platelet pressure less than 30, and oxygen to FiO ratio more than 150. That's your target on the right side. And you should follow these steps before proceeding towards mechanical ventilation. And you should advise the patients to some of the exercise to help manage your breathing pattern. Now, I'm going to the slide itself is explanatory. I'm not going to spend much time here. I will say partially breathing, how to breathe in through the nose, and when you breathe out through the lips, like a partially breathing. Breathing in one steps, breathe out in 1 or 2 steps. Keep cool. The thing is that addition of oxygen will not make you feel less breathless. This is actually the panel recommendation on the disease severity. This is not hospitalized, mild to moderate COVID-19. If the patient is not hospitalized, mild to moderate COVID-19 patient, there is no scope to use corticosteroid or any other drug, or like remdesivir should not be used. But hospitalized but does not require supplemental oxygen. When the patient is hospitalized, then also if doesn't require oxygen, there is no scope of using steroid or dexamethasone. But you may use remdesivir, though there is insufficient data. Next level is that the patient is hospitalized and required supplemental oxygen, but doesn't require high flow. Then you use remdesivir, who require minimum oxygen, and also add dexamethasone. And but those hospitalized patients who require oxygen delivery through high flow devices or non-invasive ventilation, it is mandatory to use dexamethasone plus remdesivir. And this is about the management guideline in Bangladesh. The concise form is already been discussed. In mild cases, if there is only danger signs, we'll have to go to the hospital. If the patient is a high risk patient, they will be admitted. Otherwise, in mild cases, just supportive and symptomatic treatment. We do not advise polypharmacy or many drugs. Simply paracetamol and other things is advised. In moderate cases, if there is radiological evidence of pneumonia and SpO2 90 to 93%, oxygen support, remdesivir, systemic steroid, and anticoagulant. Severe cases, as we already discussed, the patient should be admitted and treatment should be followed accordingly. About anticoagulant, I need to say a few words about anticoagulant. Any patients admitted in a hospital, there should be DBT prophylaxis. If the patient is non-critically ill and BMI less than 40 milligrams subcutaneously once daily. If BMI more than 40, 60 milligram, 40 milligrams subcutaneously BD. But if creatine clearance is less than 30, we'll have to up to 15 to 30. Still, you can use low molecular weight heparin 30 milligrams subcutaneously once daily. And if it is creatine clearance is less than 15, you'll have to switch over to the unfractionated heparin. And if there is a severe or critically ill patient, if you look to the left side, high dose enoxaparin prophylaxis is being advocated. This is the gentleman who destroyed many things, unfortunately. This gentleman used monoclonal antibody also, and he used remdesivir, he used monoclonal antibodies, he used all sort of experimental drug. See, there are a lot of monoclonal antibodies. So neutralizing monoclonal antibodies for treatment of COVID-19 is from S14 receptor binding domain, and this casirivimab antibody prevents viral shedding, and there are many more receptor binding domain antibodies, bamlanivimab, and lot others antibody are there, molnupiravir also. This is about the use of steroid in recovery trial. All of you know, meanwhile, there is a large trial. There is 6,425 patients. A recovery trial shows the benefit of using steroid in hypoxic patients. So this is the COVID-19 case severity. More about the recovery trial. Was the benefit was there? How many patients require mechanical ventilation, not require mechanical ventilation required. So ultimately, let us talk about few words about the antiviral drug. Remdesivir is a pro-drug. It is basically a nucleotide analog inhibitor of RNA-directed RNA polymerase. So it incorporates into the nascent viral RNA chains and results in premature termination. This was in a compassionate use. Clinical improvement was there in hospitalization observed in patients with severe COVID-19 cases. But this was also early closure of trial in China. Trial did not attain predetermined sample size due to the control of COVID-19 outbreak in China. That was the reason it was prematurely closed there. So there was any adaptive COVID-19 treatment trial was there. And there was simple trial also, simple COVID-19 severe cases. There is a phase 3 randomized open label multi-center study. And the key outcome was there was a clinical improvements. You can see more than 2 points on ordinal scale, and there were good improvement according to the report. But there was also another trial where it said remdesivir phase to prevent COVID-19 deaths in huge trial also. Now there was another one. You see the baricitinib. It is being used in our country as well. Some of the cases we use baricitinib plus remdesivir for hospitalized adult patient with COVID-19. There was a double-blind multi-center randomized control trial was there. It reduces recovery time and accelerated improvement in clinical state. We had another study in Bangladesh with ICD-DRB, a 5-day course of ivermectin for the treatment of COVID-19. It is actually a very small trial. It though shows reduce the duration of illness. But WHO advises that ivermectin only be used to treat COVID-19 within clinical trials. There were many clinical trials in Bangladesh, though regarding the strength of this study is doubtful. So it's a variable. So their treatment approach of patients with COVID-19, and also they have shown tocilizumab plus bevacizumab, but you see the p-value, and tocilizumab single use double use. A lot of studies are there. Now, what's the problem is that low value medical care. If we look, I'm not sure is this the doctor advice. If it's the left side, azithromycin, doxycycline, ivermectin, hydroxychloroquine, vitamin C, vitamin D, zinc, acetylcysteine, inhale, budesonide, dexamethasone, favipiravir, anticoagulant, rivaroxamin without increased thrombotic risk. So these are against recommendation of most international experts. Broad spectrum antibiotics are added under this pretext of treating secondary infections. Sam. সরি একটু আমি একটা ক্লাসে আছি একটা ক্লাসে একটু পরে ধরে Sorry, I was just interrupted by serious patient concern. It's a little bit deviated. I beg apology for that. And if it is a right side, because we are always in the running in the emergency, that's why it's very tough for us. You see, the battery of diagnostics has also been conducted for patients. Many unnecessary investigation was done for COVID-19, blood test, sugar, D-dimer, interleukin, procal, CRP, ferritin. These tests are repeated and treatment is escalated on the basis of small change in the result of these tests. Guideline do not recommend these tests for patients with mild to moderate COVID-19 disease. So the pandemic accelerated what we can do, number of new corona cases day by day increasing. So what is happening beyond the health crisis, the important impact on all of the society. So national restriction, international movement restrictions, a lot of crisis was there. Then COVID-19 is spreaded more easily in certain setting. You see crowded place, close contrast, confined and closed places as well. This is a multifaceted pandemic started. Situation day by day worsened. What happened to India? Economy reopened and many unmasked at the first wave. Too few vaccinated despite embarking on the world's largest vaccination campaign. The holy deep will wash away all infections. The Kumbh returnees are driving Rajasthan COVID grab up mass gathering event. So Kumbh Mela turns into super spreader event. 1,701 people tested COVID-19 positive between April 10 to 14. So the pneumonitis of the B1617, B1.617 more transmissible. The response to monoclonal antibody or no? No clear evidence yet of any difference in disease severity. So what ultimately unprecedented deaths India took less than a month to record its last 1 lakh deaths. So these are the reports from under struggle of the magnitude under counting. So ultimately new things came up. The Microsis. Till India reported nearly 9,000 cases of the rare infection, and it declared as an epidemic in 4 states. Now the global partnership. There are a lot of vaccines. So there are 154 in clinical evaluation, 44 in clinical evaluation, 10 in phase 3 trial. 31.3 billion US dollar is the total investment searching for global synergy. But no one is safe until everyone is safe. Mis and disinformation complicates the pictures. In an infodemic tsunami of information, there some are accurate, some are not. That is spread alongside an epidemic and pandemic. So managing infodemic became more challenging with rapid spread of mis and disinformation. Misinformation generated mistrust, and managing the infodemic management is critical to managing the pandemic. So stage 5, COVID-19 vaccine accelerated development. To 65 million vaccine dose has been administered till today. 2 doses of COVID vaccine provide effective protection against variant in India. And you see now the another big problem which we will be facing in the coming times is that I'm not sure how many days we will have to face this problem, this long COVID. The illness that is the people who have either recovered from the COVID-19 but still report lasting effects of the COVID, or have had just usual symptom for longer than would be expected. So what is happening to the COVID-19 related symptoms? These will persist in the COVID-19 follow-up. There's all of the symptoms like fatigue, dyspnea, joint pain, chest pain, cough, anosmia, rhinitis, dysgeusia, headache, lack of appetite, sore throat, vertigo, myalgia, diarrhea. These symptoms, if continues in the post-COVID period, those who are more in the risk factor, this seems to be those who are in a female phase, sex, early dyspnea, more than 5 initial symptoms, and those who are D-dimer is very high, and functional rehabilitation require light aerobic and breathing exercise. A lot of pro-inflammatory cytokines are there, so they will be of who are having more lung damages, and unresolved inflammation is there like lymphopenia, autoimmunity, gut dysbiosis, viral persistence will have long COVID symptoms, uncertain endpoints. There are a lot of study regarding the particular clinical characteristics of the long COVID symptoms. Follow-up duration is still not completed, so how many days it will persist yet to be determined. There are many, many problems with these patients, from joint pain, chest pain to worsening quality of the wards, and including fuzzy brain. I'm not sure why the slide is not moving. The possibly stop this one or not? Time is over.
Sir, you can continue if you would
Hello.
like. Sir, you can continue if you would like, sir.
I'm not sure it stopped. Did you stop the sharing or not? That's why I'm little
No, sir. No, sir. Sharing is still on, sir.
really. Oh,
Now it's off.
I
Now it's
was not getting it.
so
Uh,
now it's
uh, I'm not sure with this because the infodemic, what I say, the information other my teachers might be very much exhausted listening all this information. I wanted to just share few more slides. I believe I can complete within next 5 minutes. If you allow, I can just continue this.
Carry on,
sir.
Kabir.
You can allow
Thank you, sir.
15
Can I
minutes
go
more,
to the next slide?
sir.
I'm not sure what's happening to this slide. It's not going faster. Well, some sort of technical difficulties, maybe.
কবির তোমার এখানে বোধহয় স্লাইড নাই because
Let's stop now.
no, yes, the slide is finished. Somehow the slide is finished. You see,
All
there
right.
are no slides. Yeah,
All right, stop
you,
this one.
you can conclude.
I believe the
Yeah.
slide finished. I had few more slides unable to display due to the technical problem. There were few slides on anticoagulant. Anyhow, it's already been discussed about the anticoagulant uses and a lot of information. I try to put all this together because the subject given is vast. I was not asked to pinpoint in any specific area. So this updating COVID-19 is really very difficult. I'm not sure where to begin, where to end. So I tried to put some of the present problem and future crisis. Thank you indeed for listening all these things. Thank you, sir.
Thank you so much, sir, for your amazing presentation. I can see many questions in the comment section, but I firstly apologize because we won't be able to answer all of the questions, but we will try to answer as much as possible. To start the session, let me request Dr. Mousumi Sanyal to start the question and answer session.
Thank you, Dr. Prince. Now we are entering to the session of question and answer. So, looking at the comment box, if there is a question is available or not. But before going to the session, I'd like to thank Professor Ahmedul sir for the brilliant presentation. Sir has covered almost all the era of COVID pandemic. Though it's so till date, it's not ending or the non ever non-ending, but has described pathophysiology, and also the most important thing is Sir has discussed about the infodemic. That is, I think in Facebook I have seen that someone has already commented that infodemic is more dangerous than the pandemic, and I also think so. So Sir has described everything, and including the anticoagulation, oxygen therapy, everything. So we hopefully will have a very good question answer session. So looking at the comment box, if any question is available there. Dr. Prince, can you tell me? I cannot see any question in our comment box. So can you please tell me if I'm missing something or not? Should I check the Facebook? Okay.
You can see the question in the you can see the questions displayed in the screen. Can you?
Okay. Yeah, I can see one. Yeah, thank you. Thank you very much.
Okay.
So,
Okay.
Prof. Ahmedul, sir, we have one question. Um, Why anti-helmintic drugs omitted 9% before steroid, as that is important for prevention of spondylitis infection might cause septic shock? That's a
Oh,
difficult question.
that's a good point. We possibly we gave this in our broader version. Ivermectin is being used in those who are use steroid. There is because the Bangladesh condition, when you use steroid, we can routinely use ivermectin to prevent this trangulodisis infection. It's been given our guideline most likely. If Tariq sir can remember that, the big version where we can use it, we have given, but not in the shorter version.
Okay. So the next question is, can JAK2 inhibitors cause opportunistic microsis? So yeah, very good question, because JAK2 inhibitors are very well known for COVID infection. So that is a very good
Uh,
question.
well,
Professor
this is
Ahmedul.
yeah, yes, this is very premature to comment on these issues because tocilizumab, JAK2 inhibitor, and many others immunomodulatory drug is being used. Still, the steroid is established for this situation, and not yet any report is there confirmatory that this can cause fungal infection or mucormycosis. That could be a possibility because these immunomodulatory drug are associated with immunoparesis as well. So there is a possibility, but not yet any solid information is there to say straightforward about these things.
Okay, so all kind of immunosuppressive drug can cause any fungal infection. Okay, so moving to the next question. Sir, is there any latest update regarding vaccine effectivity on different variants and vaccine protection period? Professor Ahmed,
This
sir.
this is a very important and valid question, I believe, because what is the latest is that if you look at the vaccine, there are many vaccines in the surface at the moment. There are some conventional vaccine. There is the kill inactivated vaccine like Sinovac, Sinopharm. This efficacy is very low, nearly 50 or 60% efficacy of this vaccine. And there are some viral vector protein like Oxford AstraZeneca vaccine and many others which are little bit better than the vaccine. And the newer update is mRNA vaccine. There is the Pfizer vaccine. These are really very effective. And the latest update is the protein subunit vaccine. As you know that this is Novavax. Just yesterday there was a report from Novavax. There's a 90% efficacy of this vaccine, which is very safe and can be produced very easily. Million billion doses can be produced. This protein subunit vaccine, and the main strength of this vaccine it is the RBD receptor binding domain protein antibody, which is being used here, and the other spike protein antibody. That's why the mutant virus can easily go against it. But RBD dimeric vaccine, one in the on the last stage, that is which one is in the last stage? Is the, another one is the Gfivax, which will come very soon. Already given in the phase 3 trial, already 60 million doses given with a very good success, and this vaccine will be unblinded on the August. And this is another vaccine which adjuvant is being used in a different way. So the immunogenicity is also very high, and it believed that it will work with against all variants. And there are many other vaccine in the pipeline and inhalation and nasal vaccines are coming, where the all South African, Indian, and other variant spike protein will be used to combat all these variants. Thank you.
Thank you, sir, for the nice explanation. So the thing is that lots of new types of vaccines are in the pipeline, but the warning thing is that I think new kind of variants are also in the pipeline because in latest news I have seen that Afghanistan is facing some kind of COVID pandemic. So till date Afghanistan was out of this pandemic era, but now there is another. I think Afghanistan variant is coming on. So I think so more researchers, so more vaccines, and from the nature side, so more variants as well. Let's see what happens next. So the next question is how to differentiate hyperglycemia, whether due to steroid use or due to COVID-19. Very important topic, hyperglycemia and COVID-19. Professor Ahmedul, sir.
Okay, the thing is that steroid causes hyperglycemia. It is proven. But now what is happening to the COVID? COVID itself damages the pancreatic beta cell as well. So many of the patients are newly getting diabetes following COVID. So if you use a steroid, you know that you have been using a steroid that can lead rise to hyperglycemia. If somebody is not using steroid but developing diabetes, that is related to the COVID infection, leading rise to pancreatic beta cell damages.
Thank you, sir. So the next question is, should we worry about ADE? I think it would be adverse drug effect
Adverse drug effect.
who are vaccinated.
What sort
Professor
of
Ahmed.
adverse drug effect he mean? I don't know. Should you worried about the adverse drug effect who are vaccinated? See, if you are vaccinated, what sort of adverse drug effect you are expecting? You are vaccinated means you are having immunity against the COVID. You are not getting susceptible to other drug adverse effect.
Okay, thank you, sir. So the next question is, what should be done to minimize the irrational use of antibiotics and some other drugs in mild cases, even from government hospitals by registered doctors? Very important question in this context.
I think this is a very policy level question. And as a clinician, we can talk, we can disseminate scientific information, but this is a regulatory question more or less. And one thing, if we can do, I'm not sure what actually they can do. If they can just stop the selling of the medicine without prescription, that will not be sufficient enough. As the question is that registered physician, if you use the drugs, I'm not sure Professor Kaji Tariq sir also can highlight on these issues, how to overcome this problem. It's really very difficult because we are also puzzled seeing many registered physician also using many drugs. There is a sense of responsibility and their ethical issues. Why should they are using this? I am not going to tell much about this,
Professor Kabir, this is very
sir.
important, but the portion you have mentioned in the country where a quack is prescribing meropenem, you cannot control this. And there is
Sir,
no
exactly.
drug control monitoring system in our country. So it is rather just for discussion. If the country grows well, we are educated, we will get the benefit in future. But it is even our graduate doctors are abusing and prescribing many drugs. So next question, I think for Professor Kabir will be nice.
This is a Professor Nazmullah Hassan sir. He is joined from many mile abroad. Thank you for excellent presentation. I'm not sure how excellent it was. No single vaccine is 100% effective. Whether one can take two types of vaccine, DNA, mRNA, RNA. To be very true, no vaccine is yet 100% effective. It's true. Two types of vaccine. There are many trials. I'm not sure whether the trial result yet published or not. Until the trial result is published, we cannot have any recommendation at the moment, sir.
I can add a point because tomorrow I'm going to talk on vaccine update in
Okay,
an
sure.
international platform. Uh, Inactivated vaccine, if they take two, they can take the third dose. Or if it is not available after the first dose, Only then the mRNA vaccine can be added. This trial will come up very soon because it is in the 2-3 center. It is going on in Spain, in Australia. So let us wait. But still, mix of vaccine at this moment we cannot comment.
Thank you, sir.
Thank you, sir. Thank you, sir, for the nice explanation, and also many, many thanks to Nazmul Hassan, sir, Professor Nazmul Hassan, sir, for the nice question. We have another question in the row. So, Topon Kumar Rai asked, Assalamu alaikum, sir. Other than remdesivir, is there any antiviral drug in pipeline? Professor
Yes,
Ahmed.
many antiviral drugs are in the pipeline. I think molnupiravir will get very soon they will get the approval very soon. And there were some other these are not antiviral basically, these are monoclonal antibody.
Yeah, yeah. I
Regarding
think
antiviral
anti.
drug, at the moment there were some work going on, but still no antiviral drug came in the market. There are some monoclonal antibodies are there, like others are there. Sir, Kaji Tarik sir, would you like to add anything here?
No, no, no. You have answered sufficiently. It's okay.
Sir, this will
So
be
the
the
next.
last question, sir.
Okay, so the last question is, can we do thromboprophylaxis in a patient with dengue hemorrhagic fever with moderate COVID-19 disease with comorbidity? Very good question, because the epidemic dengue is coming again. So I think we'll face some combination of dengue and COVID-19, and that will be devastating. So Professor Ahmedul Kobisan.
This is definitely a tricky question, and this depends on the individual clinician who is treating the patient. He must judge what is the risk factor associated. If the dengue, he is saying dengue hemorrhagic, all the dengue hemorrhagic fever is not that. If it is putting the criteria, platelet count less than 1 lakh and hematocrit more than 20%. What we are saying is that if, according to definition, it can be hemorrhagic, but you must judge according to the patient, because thromboprophylaxis in moderate COVID-19 disease, if the patient doesn't have any hypoxia or other problem, so if the platelet count is very low, less than 25,000, and the patient is severely ill, in that case, you must think of the risk benefit. You cannot give in that case a low molecular weight heparin. But if the platelet count is good and the patient is severely COVID-19 cases, the risk is more on the COVID side, you should add anticoagulant. You must judge the patient, because it is a both way sword. We should look carefully about the platelet count, patient's clinical condition, and COVID crisis as well. The which one you think needed to be treated earlier, that has to be decided. This type of problem we faced with one of the associate professor who was admitted. I believe Tariq sir can remember, with Dr.
Yes,
Aparna,
yes,
who
yes,
had
yes.
dengue as well as COVID severe condition. So we did not, we used anticoagulant because platelet count was good, though she was having dengue. So finally, we came up with a good result.
Thank you,
Any more
sir, for
questions?
the nice answer and the explanation, and also thank you to Professor Khalidul Islam sir for the nice input. Now we are moving to the panel of experts. So I would request Professor Aniruddha sir for his nice opinion regarding the update in COVID-19. Professor Aniruddha sir.
Okay, can you hear me? Hello, can you hear me?
Yes,
শোনা
sir.
যাচ্ছে অনেকগুলো বলো।
Sir, the respect to all my teachers, whom I can see in the as a chairperson and others, and thanks to American College of Physicians Bangladesh chapter for letting me into this wonderful presentation. First, I thank Professor Ahmedul Kabir for his excellent presentation. He has covered almost everything in for the current COVID situation, and we are really benefited with the comments from our respected Professor Tarikul Islam sir. for most of us or almost all of us in medicine is our teacher. Professor Ahmedul Kabir sir started the presentation with worsening chamber situation. I have nothing much to add. I have just few comments or complimentary comments. Professor Ahmedul Kabir started the presentation with his worsening chamber situation. That was exactly in my mind when I came to join this webinar, because for the last few days we are getting more and more patients with fever and other symptoms of COVID. As he has clearly mentioned that this was not the scenario a week or a few days back. So we have to be careful. And in Chittagong, we also got patients who visited the north part of Bengal, or who had others who visited north of North Bengal and visited the patient also. And to add to this, before joining this webinar, I was in a call Zoom meeting for one of our doctors. She is a pregnant lady with 32 plus weeks of pregnancy, now intubated with renal failure, intrauterine death of her baby, and surviving merely having a severe cytokine storm. So these are very frustrating or heart-rending, heartbreaking situations. In the situation, in the presentation, Professor Ahmedul Kabir said about mass gathering. He cited few examples of mass gathering around the world which worsened the situation. We didn't learn from that teaching. We didn't learn from that experiences around the world, and now we are suffering. Uh, and this is what my concern is. This will put our health system under pressure again, because over 1 year we are now in a situation that we can handle the COVID cases or the COVID situation much better than we could 1 year ago. We just completed the data analysis of the verbal autopsy of around 150 cases of COVID deaths from March to September, who died from March to September in Chittagong, Kumilla and Cox's Bazar district. And we had the result now. This result, I'm not going into details of this result, but this result clearly gives us a picture of the chaotic or confused situation that we were. Not only the healthcare personnel, both the healthcare personnel and the patients or the relatives of the patients, that we were in that time regarding COVID. This is horrible. And the Professor Ahmedul Kabir has depicted the pathophysiology and the temporal progression of the pathophysiology under which we based our treatment guideline, or we treated the patient. That in the first week of the uh, illness, there will be only viral pneumonia. In the second week, there will be uh, cytokine release, either cytokine release, exaggerated cytokine release, or there will be cytokine storm. And according to that, we developed our treatment plan. But for the last few days or a week, we had some present. I discussed it personally with my colleague. We are having patient with respiratory distress within 2 to 3 days of their stated illness, that they are admitting their illness for only 2 to 3 days or 4 days, but they are now having respiratory distress and they are being admitted because they have their oxygen saturation below 94 or 93, and they are now in hospital. So every one of us is concerned about the new the new variants or others. But my concern is whether there is a new pathophysiology with the new variants. This is very, very premature. This is very, very premature comment, but I am just concerned, and I think that we should keep an eye about it. About it. Regarding the baricitinib and tocilizumab use, recently from in the June this month, the UpToDate has updated their information or their, this is not a guideline, but UpToDate had updated their website with recent data on the baricitinib and tocilizumab, where they say that the baricitinib and tocilizumab may be useful in moderate and severe cases, because many of us are proponent or many of us are opponent of using this drug, but these are hardcore evidence. Still, the randomized control trial they cited is not yet published, and another one that has been published as uh, I'm not sure that that it has much weight or other things. Still, they are considering it, because there are times we know that most of the patients improve without much intervention or minimum intervention, but there are some times when we see a patient deteriorating or progressing from moderate to severe disease, and then we ask ourselves whether should we have used the baricitinib or tocilizumab earlier. That is also a question to our respected teachers, Professor Qazi Tarikul Islam, Professor Ahmed, of course, Professor Ahmedul Kabir, sir, and other respected teachers. This is just my thought. Regarding the prophylaxis, there was a thought that the coagulation defect or the thrombosis or the okay, the coagulation defect in the COVID-19 is a two-phased has a two-phase pathophysiology. In the first phase, the thrombosis is more prominent, but in the later or more later part of the disease, when the patient is in severe disease, the mm, the more, but to say, active part is not the thrombosis, it is the bleeding part of the consumption coagulopathy, if we think it as a consumption coagulopathy. So the recommendation or some of the suggestions regarding the prophylaxis is that we can use the prophylaxis according to the guideline, whether the patient has other risk factor and others in the initial part of the in the initial part of the disease or moderate part of the disease, but when the patient is very severe or very severe or in critical phase, the thromboprophylaxis, the enthusiastic thromboprophylaxis has proven rather harmful. So there is a new guideline for thromboprophylaxis in UpToDate. Now, this is not a WHO guideline or others, just a new recommendation for thromboprophylaxis in UpToDate. So anyone who wants to go through it can go through it. Monoclonal, regarding the monoclonal antibody, now I think this is one more or less, what to say, if not recommended, more or less accepted treatment, but in the earlier part of the illness, not in the later parts of the illness. Regarding the uh, one study, the extraordinary survival benefit of the tocilizumab and others, Professor Ahmedul Kabir sir has mentioned. I have gone through this study, but I didn't find any inclusion criteria, exclusion criteria, how they selected which patient should get what drug. I am sure that Professor Ahmedul Kabir sir has clearly pointed out it. So I am not very much convinced that whether there was a proper randomization. Just rather I thought that it was a case series. They have first treated the patient whatever according to whatever they wish, and later on they publish the data
They
that
included all
this
this.
what happened. But this is not a proper randomized control trial, and we cannot draw any conclusion from this. The ivermectin. This is a very important issue. few of the countries, if I can say okay, the accepted term is the least or less developed countries. Least or less developed countries, or the tropical countries where this kind of infection is prominent, they see some benefit using ivermectin, not regarding COVID, regarding strongylosis or other things, because they now comment that we know that this is a condition where the immunity becomes compromised, and we are using steroid and other immunity lowering drugs. So if the patient has already strongyloid infection, it may turn into hyperinfection syndrome and others. Just let me tell you, just within last week, we diagnosed a patient who was having post-COVID problems with hypereosinophilia. Then we did the stool examination, and the patient has had strongylosis. We started treatment of the strongylosis with the ivermectin and the it was not, it was leukocytes, but eosinophilic leukocytes. It was coming very quickly coming down. My experience is, since the COVID, when the pandemic first struck us, we didn't have any evidence. So at that time, what we did was the eminence-based practice. That is what our senior teachers, or the what to say, Sir Kazi Tarikul Islam sir or others, the eminent professor, what they thought over their lifetime experiences, ওনাদের প্রজ্ঞা যেটা বলেছে, যেভাবে করতে বলেছে আমরা সেভাবে করেছি। চিকিৎসা করতে 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 we gained some experience. Then we incorporated our experiences into our treatment. But these are not evidence-based medicine. Nowadays, we are now getting more and more evidence-based recommendations from different societies, WHO and others over the world. So now it is time to get into a practice which is now evidence based. আমরা আর এখন বলতে পারবো না যে আমরা কিছু জানি না। যদ্দূর জানি, এর মধ্যে যদ্দূর এভিডেন্স গ্যাদার হয়েছে, স্টিল দেয়ার উইল বি সাম caveats which we cannot fill, যে এইটার কোনো এভিডেন্স নেই, এটা কি করব। দেন উই লুক ফরওয়ার্ড টু আওয়ার টিচার্স লাইক তারিকুল ইসলাম স্যার, যে আপনারা কি বলেন, আমরা এটা বুঝতে পারছি না, আপনারা কি বলেন, কোনো এভিডেন্স নেই, আমাদের কোনো এক্সপিরিয়েন্স নেই, আপনি যে আপনারা উনি বা ওনার মতো যারা আছেন আমাদের অন্যান্যরা, আপনারা যেটা বলেন আমরা সেটা করব। ইট উইল হ্যাপেন ওভার টাইম। হয়তো হতে পারে যে এখন যেটা ঠিক মনে হচ্ছে, পরে গিয়ে এটা ঠিক মনে নাও হতে পারে। বাট এই আমি আসলে আমার যতদূর আমি বুঝেছি বা জেনেছি, এটা বলার চেষ্টা করলাম। থ্যাংক ইউ ভেরি মাচ ফর লিসেনিং টু মি। এবং আবারও আমার স্যাররা আছেন, তরিকুল ইসলাম স্যার আছেন, আহমেদ হোসেন স্যার আছেন। They will correct me if there is anything I said which is not scientifically correct. Thank you very much, and thank you Mousumi for your excellent
Thank you,
presentation
sir.
and
Thank you, sir, for
moderation.
your nice and excellent explanation. And I should say that you have picked up the important and very important rules of this presentation. I think in the last of our presentation, Dr. Sir will explain all our questions and all these important queries regarding the COVID-19. So now, right at this moment, I move to Professor Ahmed sir for his expert opinion regarding outbreak of COVID-19. Professor Ahmed sir. Sir, please unmute your mic. Sir, would you please unmute your mic?
It is unmuted.
Sir's
All right, we
mic
can
is
listen.
unmuted, but
Sir, please
I
unmute your
I
mic.
think Sir's microphone is not working right now. It
I
is
think
unmuted.
someone has to call him over phone. Otherwise,
Sir, can you listen to us?
sir, please unmute the microphone.
Sir's microphone is unmuted, but
Oh,
he
so he
haven't
cannot
connected
hear.
with.
Maybe
You
he's
haven't
connected
connected
to
to your
the
own
microphone.
microphone. That's the problem.
Let us wait. I think his son has
Someone is coming here.
got, yeah,
Someone.
ওই ইয়ারফোন আনতে গিয়েছে ছেলে, আমার মনে হয় এখনই কানেক্টেড হয়ে যাবে।
Can you hear me now?
Yes,
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 sir.
Yes,
yes,
sir.
We
yes.
Yes,
can
sir.
hear you.
You're
Oh,
yeah.
sorry. I was not
No worries.
first used this microphone, but now I thank Dr. Mousumi for his nice moderation, and I congratulate Professor Ahmedul Kabir for his very excellent presentation on this update on COVID-19. And I like to pay my respect to my teacher, Professor Kaji Islam sir, chairperson of this session, and also uh, my teacher, Dr. Professor Nazmul Hassan sir, the present governor of ACP, for inviting me to be here in this very important session as a panelist. So Dr. Ahmedul Kabir has covered almost all things and COVID-19 and its update. And Professor Aniruddha Ghose, he raised some of his experiences and some of his queries. So at this moment, I think we should stick to the recommendations which are provided by some the recognized bodies like WHO or CDC, and definitely we should come. We should be in contact with the what are the new researches are happening and with the new informations. So now with this situation, at the beginning of, I think the third wave, we are probably we are facing, going to face, as already the districts, the border districts with India, uh, there is a situation is gradually worsening, and also the near districts also having the increasing infection of COVID. And at this moment, we are also seeing the increasing rate. So we should be watchful, and we should follow the uh, recommended guidelines. And we should not use the indiscriminate drugs, antibiotics, and a lot of things are going to is going to be used in this COVID infection. And with this, we are uh, uh, escalating. So we are going to create some new problems. Like in India, already the Microsis is a pandemic. Already, Professor Ahmed Kabir has mentioned because of these post-COVID conditions, especially due to use of steroid and other immunosuppressants. So, in this perspective, we should be careful in using the drugs and when we should use the steroid and also other drugs, especially tocilizumab and baricitinib, should not be used indiscriminately. And from this session, we have learned many things. And also from the comment from Professor Aniruddha, we also enriched our knowledge and with some query regarding use of prophylaxis, thrombo and others. So I think Professor Tarikul Islam sir will give his final comment on this. I thank again the present uh, uh, sirs, especially Tariq sir, Professor Aniruddha, Professor Ahmedul Kabir for their very enriched presentation. And I thank again Dr. Mousumi Sanyal and Dr. Prince for their very fruitful help in going through this session. Thank you. I'm over. Thank you very much.
Thank you, Professor Ahmed Sir, for your nice comment. That was really valuable for us. And now we are moving towards the end of our today's presentation. And last but not the least, I request our Honorable Professor Tarikul Islam Sir for giving his valuable opinion. And I would expect that Sir will clear all our confusions regarding few important topics of COVID-19 updates which have Professor Aniruddha Sir has discussed, and also Professor Ahmed Sir has presented those things in his presentation. So we had a good presentation. We had a very good question answer session. Till now, I am looking at the screen that there are lots of comments is coming regarding today's presentation. So it is my intense pleasure and honor to share the screen with all these legendary professors. Now, at the end of the ceremony, I request Professor Kazi Tarikul Sir for his closing speech. Professor Kazi Tarikul Sir.
Thank you very much, Dr. Mousumi. Indeed, it was an excellent presentation from Professor Ahmedul Kabir. He is always a spellbound speaker. I must appreciate, because it is very difficult in 1 hour to talk on update on COVID-19. It's very, very difficult, because if you consider in the last few months, you can see on COVID, at least all of we have attended 1 hour multiplied by 15 dimensions. So 15 hours. So it is very difficult, but still he has made this very condensed, and he did not go all detail through this because it is not possible. And the advantage is our participants are all doctors and postgraduate trainee and many other teachers. So for them, it was very pleasant, and they could pick it up very quickly. What Mousumi told, that I will answer all the problem, is not possible for me for two reasons. Number one, in this COVID era, uh, there is geopolitics is going on regarding vaccine, especially regarding the use of the drugs, especially the pharma politics is going on. uh, I'm just giving a small example. Say, for example, what Professor Aniruddha told, that one case they have proved, this is called evidence based. They have proved that this patient, after steroid, the patient developed eosinophilic leukocytosis. They tested the stool and proved it that this is Estrangula stercoralis. But how many cases are going unrecognized, we do not know, because there is no such trial is going on. So this is one anecdotal personal experience from a professor. But at this moment, we can't say, okay, give ivermectin to everybody who is getting steroid. Steroid is being used for last 50 years, 60 years. And in autoimmune disease, bronchial asthma, and so many diseases, steroids are being used by the doctor as well as by the patient himself. But how many of them are developing a strangular stercoralis, we do not know. So this is the time we should go for this. Regarding ivermectin, it came to my ear that least developed country, they have this. But you know who is making this campaign for ivermectin? I joined in one international conference on ivermectin interested group, IIG. Anyhow, they are trying to make ivermectin a possible uh, drug that should be at prophylaxis and at mild and moderate. So what is going to happen? Some vested interest from many corners are coming. If I summarize, because already we are 1 hour 30 minutes, if we summarize all the teachers here, panelists, speaker, They are experienced. They are directly dealing with the patient. And it's a very touchy when Aniruddha was talking about one pregnant lady who already has developed IUD and she is fighting for life. These are very, very pathetic issues. And everywhere there is no, this is still, the margin is blurred. You can get a lot of information. This is NIH, this is WHO, this is that, this is that. But during this infodemic, you must try to judge by yourself who is authentic to me, who is authentic to me, and you take those one. What is the cut and borderline? This depends upon the clinician's judgment. Nobody else can give you the. You have the knowledge, you have the power, you have the different source, but a particular patient is always different from the other patient. Even though the patient is in a severe state, even though the patient is in a critical state, but every patient has got different merit. So I will request that when to use baricitinib and remdesivir, there are some instruction. When to use the tocilizumab or bevacizumab, it totally depends upon the patient's condition and the clinician's judgment. Can I going to save the life of the patient? Because above life there is nothing. But judiciously. Your conscience is your judge who will guide you that you are going on the right way, and the knowledge is your power. Because you are all professor, I may be senior to you, but you are not at all regarding the knowledge less than me. Rather, in this COVID, some months we are not directly with the patient. You people are directly with the patient, so you know better than us. We are listening from you. We are attending Zoom meeting. We are reading some literature. So you people are the best judge for your single patient and single life. Finally, I will conclude with the one important sentence: no one is safe. What Dr. Tedros has told at the beginning, Professor Kabir told, if anyone is infected on this earth, no one is safe. If and he has also asked one thing: some people of all countries should be vaccinated, then all people of some countries. So important, so important. Can you imagine? 4.2 billion people in the Asia are getting only 4.8% of the total vaccine. On the contrary, Europe and America, they are consuming 55%, where 1.7 billion people are residing. So contrast. So day before yesterday's in G7 conference, Xi Jinping told the time has changed. Only few countries will control the whole world. That has gone. But until you have developed your technology, you have to depend on. Now what is going on in Bangladesh? If we could massively vaccinated our people, the panic of third wave or surge of the second wave could not have in our mind. But we cannot. We are dependent on China, on Russia. When United States will give their extra AstraZeneca to us. So these are all theoretical until we could develop. So it is too late. Maybe we have missed some train, but better late than never. We should hope for the best. And because of this very healthy discussion, I must appreciate the presenter and the panelists and the participants. because lots of nice questions were coming. Uh, Regarding vaccine, I will tell one thing, that no vaccine is 100% efficacious, and it there are a lot of I repeat, there are a lot of variables on which the vaccine efficacy actually depends on. For example, a small example, when Pfizer did it, they took 21,000 something in the vaccinated group and the same amount in the placebo group. How 95% came? In the placebo group, 162 affected after an observation period, and in the vaccinated group, only 8 infected. So they said these two, they sum up, it came 170, and 8 of 162 is 95% with the confidence interval of 95. That is why, not only this, in real life, on the real world, it may not. You know what is the efficacy of flu shot? Only 50%. But millions of people are alive. Every year they are taking this flu shot. So only 50% is enough. There are 357 trial up to 11th of June. Only 17 is in the authorization or approval phase. Only 17, 17টি মাত্র। 357টা ট্রায়ালের মধ্যে মাত্র 17টি ব্যবহারের উপযোগী। তাহলে যে ভ্যাকসিন বের হয়েছে 9 মাসে, প্রেগন্যান্সিতে যেখানে 10 মাস 10 দিন লাগে, যে ভ্যাকসিন 9 মাসে বেরিয়েছে সেখানে অনেক লুপস এন্ড হোলস আছে। ইউ হ্যাভ টু বিলিভ ইট, ইউ হ্যাভ টু অ্যাডমিট ইট। ইভেন দেন আমরা আশা করব, আমরা যদি তাড়াতাড়ি ভ্যাকসিন পাই, আমরা একটা কমফোর্ট জোনে থাকব। আমি অনেক উপভোগ করেছি, এবং আমার প্যানেলিস্টরা এবং আমার বক্তা অসাধারণ বলেছে। সবার কন্ট্রিবিউশন চমৎকার ছিল, এবং সত্যি কথা বলতে কি, there is no limit of age of learning, even when your one leg is in the grave. Thank you very much. With all thanks to everybody, I am concluding this session. Over to Dr. Prince.
Sadly, we have come to the end of today's program. We have learned so many important things about COVID 19 from Sir today. Hope it will enhance in the process of examination. Many thanks to the speaker, the chair, the expert panel, and last but not the least, the moderator Apu for managing time for this program from their very busy schedule. I'd like to thank all the audience who were with us throughout the event, especially those who asked very important questions. Hope you got your answer. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program on our YouTube channel right after the presentation finishes. Our next masterclass will held on 17th of June, where Professor Muhammad Mujibur Rahman sir will discuss on topic management of hypertension. So, see you all in the next episode. Until then, take care.